Thanks to the introduction of effective vaccines in the 1960s, measles outbreaks had been relatively infrequent in North America as a region in recent decades. But in 2025, outbreaks in Canada, Mexico, and the United States led to thousands of cases and several deaths in all three of the countries. In October, Canada lost its elimination status, certified as having eliminated measles, and Mexico and the United States could lose that status later this year. Today, on the CommonHealth Live, I'll turn to three experts to break down what's happening in North America, why here, why now, and what this means for regional and global health security.
This is the CommonHealth Podcast, a product of the CSIS Bipartisan Alliance for Global Health Security. We engage with diverse leaders on the question of how best to navigate this period of exceptional turmoil, reform, and uncertainty in U.S. leadership.
So the last year has really seen an overall increase in measles outbreaks across the North America region. An outbreak initially reported in West Texas last January has spread north to Canada, south to Mexico, with additional outbreaks reported in states and provinces across all three countries. By the end of 2025, there had been more than 5,400 confirmed cases in Canada, nearly 2,300 in the United States, and more than 6,400 in Mexico, with deaths in all three nations as well. In October, Canada lost its certification as having eliminated measles transmission, and the United States and Mexico could lose that status later this year as cases continue to mount. Given the widespread availability of highly effective measles vaccine in the North America region, it's important to ask, what's driving these outbreaks? Why here in North America? Why now? What's at stake when we talk about the loss of measles elimination certification, and how can a country get it back? And what do these outbreaks mean for health security in the broader Americas region and globally? I'm Katherine Bliss with the CSIS Global Health Policy Center, and today I'm pleased to welcome to the CommonHealth Live three experts on measles, immunizations, and infectious diseases in North America. I'm pleased to welcome Natasha Crowcroft, Vice President of the Infectious Diseases and Vaccinations Programs Branch of the Public Health Agency of Canada, and the agency's acting chief public health officer. Bill Moss, professor and executive director of the International Vaccines Access Center at the Johns Hopkins Bloomberg School of Public Health. And Daniel Salas, executive manager of the Comprehensive Immunization Special Program at the Pan American Health Organization and former Minister of Health of Costa Rica. We will discuss the current measles outbreaks and measles elimination, what happened in 2025, and what we should be looking out for in the coming year. So Natasha, Bill, and Daniel, welcome to the CommonHealth Live.
Thank you.
So I want to start by kind of setting the stage with respect to measles in the three countries and what factors are driving these outbreaks, after such a long period of elimination and really, kind of sporadic or infrequent outbreaks in many years. Natasha, can I start with you? Can you talk about what's happened, in Canada over the last year? There were a number of cases. It kind of seems like things have quieted down for the moment, but what was driving those numbers and what are you seeing as things move forward in 2026?
Yeah, thank you, Catherine. So it's a very different outbreak to what we've seen in the past, and the context is quite different. The outbreak started in Canada in 2024, and I think it's probably best to think of it as a multi-country outbreak in a connected community across several countries, a very closely connected community. We've now experienced more than 5,500 cases in Canada. As you say, we lost our elimination status in the fall. The outbreak is now grumbling along it's not over yet. We had a little bit of an increase recently. The increases we're seeing are related to often events, like there was an agricultural fair which drove transmission. And indeed, the very first beginning of the outbreak started with an event, a perfect storm of a case, somebody who's infectious, arriving at a wedding full of people from all over Canada. And that was a great place to spread measles, honestly, like people went back home with it. So, and it landed in a community that hasn't traditionally is skeptical of vaccination. And so very highly unimmunized community. And it's really stayed in that community. Most of the cases are in that community or those communities across Canada, not spreading to the general population, which indicates that it reflects the generally reasonably good immunization coverage, even better since the outbreak, because there's nothing like an outbreak to get people caught up on their immunization. People sit up and listen when that happens. So it's a unique outbreak. And I think what we are here is the victim of our success of measles elimination since 1998 in Canada, where communities that didn't take up vaccination essentially stayed susceptible. And through this period of time, more than 25 years, people have grown up without ever catching measles. And so the numbers of susceptible people clustered in these communities has been very, very high, and hence the explosive takeoff of the outbreak as soon as a case arrived in that community.
So it sounds like this is a situation where, in addition to very young children being vulnerable, perhaps because they haven't had access to vaccination yet, there are adolescents and older adults who just have grown up in a context where it wasn't as visible. People just weren't aware of the dangers of measles in quite the same way. Bill, in the United States, we've seen, there was the outbreak in Texas last year. There have been, a series of cases in Utah, in Ohio last year. Now we're seeing a concentration of cases in South Carolina and elsewhere. Can you say, a little bit about how some of the, what you've seen over the past few years? I know you and your colleagues are looking at some of the both transmission, but also some of the different ways in which the economics of dealing with cases and outbreaks has really kind of changed the way some of the states are looking at these issues.
Yeah, certainly. Thank you, Catherine. And this year we've seen a very steep increase in the rate of new cases here in the United States, in contrast to what you and Natasha were describing for Canada. And I'll just say, here in the United States, if you look at 2025, where we had 2,281 cases, and look at the age distribution of those cases, about a quarter of those cases occurred in children younger than 5, but just under half were in children and adolescents 5 to 19 years of age, and almost a third adults 20 years or older. So this buildup of susceptibles, as we say, really has taken place over many, many years, as Natasha described for Canada. And now the CDC just updated their numbers earlier today. 982 cases reported here in the United States in 2026. We are seeing a slight shift in that age distribution, still about a quarter of cases in children under 5, but an increase in the proportion of cases in that 5 to 19 years age, which I think is reflecting the school-based outbreaks that we're seeing in South Carolina and in Florida. But my colleagues here at the International Vaccine Access Center, led by Brian Pattenow, did a updated review of the cost of these outbreaks, and it's quite striking. Obviously, the cost of an outbreak depends upon its size, but on average, over the past 20 years or so, each measles outbreak cost on average $43,000. But I think, to me, what is most striking, if you kind of take out those initial fixed costs for an outbreak investigation, each additional case costs about $16,000 for each additional case. And when you've got the numbers of cases that we have now, for example, in South Carolina and Florida, these are very expensive outbreaks. And hopefully this will help drive some of the desire to improve our vaccination coverage in some of these communities with traditionally low vaccine coverage.
So that's an expensive outbreak, and really, each additional case really adds to it. Daniel, PAHO is obviously working with countries across the Americas to both, continue to focus on immunizations, but also to, this was a region that had really achieved recognition as having eliminated measles throughout the hemisphere. Can you say a bit about what's been happening in Mexico and like what you're seeing in some of the other countries throughout the region?
Yeah, sure. Thank you, Katherine. And actually, there's definitely the problem of not reaching, high coverages, and that situation has been maintained, throughout several years in the last decade. And of course, that's impacting, the fact that we're accumulating pockets of unvaccinated. And but I mean, vaccination by itself, of course, it's really important, and we need to continue working with countries to increase the coverage, to increase the capacity of their programs to reach out to the people that really are in need. I mean, the underserved communities, that there are a lot of barriers to get there. But definitely we need to strengthen at the same time the surveillance systems and the rapid response capacity, because it's a combination of factors that if you have those three pillars, those three components strengthened, I mean, it's not probable that you're going to have a problem with measles. Probably you're going to have an importation, or probably you're going to have some like limited transmission, but that situation is not going to sustain, to convert, or to become a sustained transmission, for months or even more than a year, which is the condition that a country, I mean, that's why when you sustain the transmission by a same chain, by the same like lineage and or the same strain, is when you lose, the purification. So definitely this situation of having these pockets of unvaccinated, if you look, the trends of vaccination coverage, we need to have a 95% coverage for the first dose and the second dose. And if you see the regional numbers, I mean, the last year we increased a little bit. I mean, in 2024, the data available for the regional, chart is for 2024, and we increased the first dose. We reached 89%, and for the second dose, we are at 79%. And that's an increase because we were down. And of course, the pandemic, the COVID-19 pandemic impacted a lot to have lower coverages even. But the Americas started to experiment this decrease even before the pandemic. So it's a really concerning situation of how we need to really stratify the analysis in each country to know where those pockets of unvaccinated are, to work more on convincing people why vaccination is important, and at the same time to give the healthcare workers that are working, with populations, so that they are convinced to convey the message of why vaccination is important. We sometimes are missing this opportunity because when you have in front of you a parent or a person that requires to have the vaccination, and you don't take advantage of that opportunity to convince that person that, I mean, they need to return to continue, the second shot and the third shot. I mean, it's a matter of a missed opportunity, and you need to have that healthcare worker really, able with the tools to transmit that level of trust in vaccines. Because, I mean, we know what is going on right now with social media. We know that the hesitancy is always going to be there. There are reluctant groups, as the ones that Natasha mentioned, that of course we need to work with them, but they're like sometimes even more radical against receiving vaccines. But we need to map exactly where they are. We need to know where they move, what are their patterns, of movement. And we need to bring this shield of protection, around these populations. Because in the case of Canada, for example, the outbreak hasn't spread all over the population because, vaccination coverage are good in there. But if you start to find these pockets of unvaccinated in these kind of fragile, communities where these people that are reluctant, these groups are reluctant, that's the problem, that when the outbreaks start to, spread, and you have these problems. And of course, if you have a surveillance system that is pretty sensitive to detect, and then the rapid response is activated in a timely way, you're going to neutralize all the, the chances for the virus to continue spreading. But if you don't have those pillars, as I mentioned before, assembled in place and strengthened, the possibility of having these importations is going to remain. We eliminated measles. I mean, we were the unique region that eliminated measles in 2016, and then we recovered that in 2024. But unless we have eradication, which is the elimination in all over the world, we're going to continue having this risk and this pressure of having importations of people that travel to, other regions, and of people that comes back with the virus, or people that are visiting our region that are, carrying the virus. And being this virus so transmissible as it is, that it can infect from 12 to 18 people, just one person infected and just by talking, just by even, breathing in a room, and the virus can stay 2 hours long in that room. It's pretty, it's the most transmissible virus that we have. So, that's a situation of how to continue strengthening this progress on vaccination, by the same time, the surveillance systems and the rapid response teams, that if we don't take care of these, if we trust that the vaccination or these diseases are not going to come back, that's the problem. We can't settle down and just, wait for these outbreaks to appear again.
So you've talked about the importance of building trust within different communities that may, have not have a lot of confidence either in the health system or in vaccines in particular. But you've also really outlined kind of the importance of three pieces, right? The immunizations, but also surveillance and an adequate response for people to recognize what measles is. Exactly. Can you say a bit about the process of certification of elimination? You mentioned the importance of kind of assessing the sustained transmission, but what's involved in being certified, and what happens when that certification is lost? How does a country kind of get it again, and what does it mean?
Yeah, sure. Well, for that we have, in each region of the world there is a regional commission for the elimination and verification, monitoring and verification or verification of the elimination, of the transmission. So we are going to refer to that commission as RVC. That's the acronym for that. Mm-hmm. And that RVC is a group of experts, well recognized, internationally. And those group, that group of experts receive each annually, a report from countries. That report is prepared by the ministries of health. But we have a national committee in each country that is that counterpart of the regional commission that actually checks on the information that was prepared by the authorities, so that they're going to eventually improve the quality of that report. And that report, we have a framework that establishes all the criteria. So that report should comply with the requirements or the steps that this framework establishes. Okay. So we have the rules set, and it's all, it's very clear what that report should contain. Mm-hmm. And that report, countries of course need to, report how are the coverages, what actions are they doing to eventually increase coverages, what is going on with the surveillance systems. if they're timely detecting cases, and if they're, for example, the laboratory capacities, if the laboratory capacities are there, and how are they connecting to the network of laboratories, because we are not expecting each country to have all the laboratory capabilities on measles, but there is a network. So, and of course the rapid response. For example, the participation of communities is assessed as well. Communication, risk communication is assessed as well. So there are several factors that are there in that framework, and that annual report should comply, so that the RVC assessed the situation of each country. Once this annual meeting that usually happens here in November, happens. Then the RVC assess each country. It writes several the gaps that were found for each country, and then some recommendations. But the final decision of if a country is going to change their status, of losing the status of elimination or recovering eventually, is going to go. That assessment is going to go to the director of the Pan American Health Organization, and is the director the ones that gives the final word, and the ones that communicates officially to the ministers of health about a decision of these importance. How to recover the once the country has lost the elimination. Well, of course, if a country has lost the elimination, it is expected that country should prepare an action plan. So that those gaps that were detected in that meeting and the RVC detected, that those gaps are going to be addressed. And the RBC and of course PAHO, the Secretariat, gives follow-up to the actions that should be, take place in this action plan. And once that, of course, we have like 1 year of not having, outbreaks, not having that transmission, and the country is able to prove that has been the case, then, the RBC is going to recommend to the director that the country can recover, the previous status. But it takes 1 year of, having this kind of interruption.
Okay. So the first step then is an action plan to kind of begin to address some of the issues that were raised.
Exactly.
Well, Natasha, let me turn back to you then to, the status was lost in October. What are health agencies, both at the national and the provincial levels, doing to kind of think about how to kind of take, this next 12-month period to recover elimination or recover the status?
Yeah, so the clock doesn't start. The 12 months that Daniel referred to the clock starts ticking once we have interrupted transmission. Okay. So we're working on a plan, but we don't start working towards regaining our elimination until we have a period of no cases and we can say, okay, the outbreak is over. When we declare it over, then we can start. We're doing all the things that Daniel mentioned. We're very focused on improving immunization coverage, on strengthening our surveillance system, on making sure our response is as good as it can be. And then another piece that we haven't spoken about as much is about community engagement. We spend a lot of time reaching out to communities to try and get a good information out to the public and to tailored for specific communities. And also because I work at the federal government level, so really we try and work through partners, trusted partners. I mean, at an individual level, that's the individual pediatrician, like Bill, is somebody that, your patients will trust you much more than they'll trust me because I'm a government employee. So, we're very conscious of who do people trust. And then in specific communities, we go to the community leaders. We work with a multi-faith group that represents different faith-based communities across Canada, who help support us get messages, sometimes in the right language. It depends on the community. And that building that trust with communities, that's a very local piece of work. And that's something that our colleagues at local level in Canada have done amazing work. And in fact, some of the staff who work in public health units are from the communities that have been affected by the outbreak. And that helps a lot in terms of actions that the communities will take. I mean, even if there are individuals who don't want to accept vaccination, there are other things they can do to reduce the burden for them and for the health system. Simple things like calling ahead if you're going into hospital with a sick child, so that you don't have a situation of an infectious child sitting in the emergency department with no infection control measures because no one knew they were coming, that kind of thing. Mm-hmm. So there's things we can do to help reduce spread even when we don't have vaccine as a tool. And we have an action plan that's in development, and it'll be going to PAHO for their input as well once we're a bit further along with it. But it covers all these sorts of elements in trying to really get on top of the situation and prepare us for the future. I think there's a piece of it that we can't control, which is the global context. And every country in the world has signed up for measles elimination. Every country in the world has measles vaccine. And every region of the world has a measles elimination target. PAHO is the only region to have succeeded so far. But as long as Daniel said, as long as there's measles anywhere in the world, big increases in Europe right now with countries losing their elimination status, that places everyone else at risk. So this is really a global issue as well. So we can only go so far with our national action plan. We really do rely on getting measles control back on track everywhere so that we have fewer importations, because it's that constant flow of cases from other countries where there are outbreaks that makes it very hard to keep ahead of the virus.
So, Bill, Natasha has talked about the importance of community engagement, but also the diversity of approaches that are taken, perhaps between the federal, the provincial, and the local level. Of course, here in the United States, the 50 states, each have their own approaches to, perhaps public health funding, but also vaccine mandates and reporting and all of these issues. We've seen the numbers of non-medical vaccine exemptions really kind of rising, I think, to 3.6 or, maybe higher, percentage depending on the state in recent years. Can you say a little bit about the implications of this policy diversity kind of across this country and what that might mean for some of the regional collaborations that Daniel and Natasha have been talking about?
Yes. So first, I'll say that school vaccination requirements here in the United States were really a critical component of our measles elimination strategy, and were key to the United States achieving its measles elimination status in the year 2000, which we've been able to maintain now for a quarter century, but are at high risk of losing when PAHO debate discusses this and judges, as Daniel said, on April 13th. So I'd say, first of all, we school vaccination requirements, as you said, Catherine, are set at the state level. There may be some benefits of that, meaning that it can't be set at the federal level, but it does create enormous heterogeneity across the states. All states allow for medical exemptions for vaccinations, and there are certain medical conditions where, for example, attenuated vaccines like a measles vaccine should not be given children who are particularly immunocompromised. But where the heterogeneity lies are in the non-medical exemptions. We do have 4 states here in the U.S. That do not allow non-medical exemptions, but most states do, including religious exemptions and some personal exemptions. And, in addition to whether or not states allow non-medical exemptions, the process for attaining a non-medical exemption varies tremendously across states, where in some states it can be very simple, just a parent has to sign a form. But in other states, it's more laborious and onerous to get a non-medical exemption. And that can be a good thing. So it's not so simple. So, for example, some states will require online that a caregiver take an online educational module, for example, or even more so where the non-medical exemption form requires notarization or consultation with a health care provider. So there is great heterogeneity across the states in the non-medical exemptions, and this creates heterogeneity in the proportion of children within each state that have non-medical exemptions. I will say, I still believe firmly that most parents in the United States believe in vaccination and want to protect their children with vaccines. But as you said, Catherine, we have seen this kind of slow uptick, particularly since the COVID pandemic, in non-medical exemptions. The best data we have are from the Centers for Disease Control and Prevention annual surveys of kindergarten students. And the last number we have for non-medical exemptions across these kindergarten students is 3.6% nationally for the 2024-2025 school year. But this varies widely across states. In Idaho, for example, it's as high as 15% of non-medical exemptions. And concurrent with that, we've seen a slow decrease in the proportion of kindergarten students who are receiving 2 doses of the measles, mumps, and rubella vaccine, where it's dipped down now to below 93%, just below 92.5% in the last survey. These trends, I'm afraid, are going to continue as we see more legislation introduced into states to not only kind of potentially get rid of school entry vaccination requirements, as has been proposed in Florida or Arizona, but also in those states that allow, have non-medical exemptions, to ease the process. So, for example, we're seeing that in Utah, where there's state legislation that has been proposed to eliminate the need for an online educational module, and a parent caregiver can just sign a form to just make that process easier. Though this proposed legislation that we're seeing in states will further lead to higher proportions of children receiving non-medical exemptions and a lower measles, mumps, and rubella vaccination coverage among these students, and then a higher risk for the outbreaks that we're seeing among schools right now in South Carolina and in Florida.
So it sounds like there's as you said, a lot of heterogeneity, and not just between the states, but even at the county level and within localities and schools, kind of depending on a number of different factors. So it's late February right now. We're kind of wrapping up the Winter Olympics, but the next on the horizon, of course, we've got the FIFA World Cup, coming here to North America, coming to cities, in all three countries, in Mexico, the United States, and Canada. And so I wanted to, ask each of you to, just say a little bit about, the extent to which these gatherings, like the wedding, Natasha, that you mentioned, or some of these other kinds of mass events, we've even got spring break, coming up in a few weeks, where people will be traveling all over the region. What do these, big sort of gatherings or movements of people, kind of suggest about the vulnerability of this region, either to imported cases or to, kind of further spread? And what are some of the steps that officials could be taking now to try to prevent any kind of a challenge? Danielle, maybe I'll start with you.
Yeah, sure. Well, the first thing is that we need to accept that events are going to continue happening. The mass gatherings, concerts, religious movements, the World Cup, whatever, Olympics. Mm-hmm. It's part of, our dynamics as society. So it's something that we need to accept. It's a reality, of course. That's why we need to continue working on convincing people to get, timely vaccination. Because, if those activities happen, but you have people vaccinated there, or most of them are vaccinated, mm-hmm. It's highly unlikely. And the people that are living around them are vaccinated, it's highly unlikely that that's going to turn into a situation of sustained transmission. So definitely, that work of continuously working on convincing people the importance of vaccination, even though they are not seeing the effects of many of these outbreaks, but probably that's part of of why we are failing. Because in the past, when we had these large outbreaks of measles everywhere, it was very common to see children and even adults hospitalized because of a pneumonia, because of an encephalitis. And there is a recent discovery, I would say more recent, of the immunamnesia, for example. Immunamnesia happen very frequently with infections in unvaccinated people, with when they are infected with measles. Mm-hmm. And it turns out that this is more than 50% of people that got infected. And people are not seeing that the hospitalizations, the complications of having a resetting of many of the, defenses, the antibodies, the lymphocytes, or the cells that, are defending our body against these, different bacteria and viruses. And there is a 38% more hospitalization in the month after a mild, eventually, or any infection because of measles. 38% the next month because of other causes. And that's something that I think that we need. It is not to promote fear or to, say people, if you don't do this, but it's part of how viruses work. And this particular virus is very transmissible, and it's the only one that can cause this immunamnesia that, it's something that, parents should be more concerned, or even themselves, because the complications are more frequent in children less than 5 years and in adults older than 20. So it's something that need to call attention. Even 7 or 10 years after an episode of a measles infection, it can happen an encephalitis that most of them of these cases are, going to be dead. I mean, it's something that it's a fatal condition. But definitely we need to continue spreading the message. Healthcare workers, as Natasha was mentioning, work with communities, religious leaders. It's this part of community engagement. Of course, the healthcare workers still continue to be the number one reference for, public in terms of health. But now that we have social media and misinformation is spreading as the virus, it is important to work at the community level. So that, this importance of vaccination is there, is positioned everywhere. We need to get the governors, the leaders in the community, the private sector. It's a matter of building this trust, towards vaccination and vaccines again, because we somehow have lost this. And of course, the barriers that I was mentioning before, because, for example, for indigenous population, that unfortunately they're the ones that are suffering more in terms of deaths in this current outbreak. We know that sometimes they're underserved. That the visits or the access that they have to, healthcare centers is very limited or non-existent.
So it's not just immunizations, but the broader access to primary health care and other services.
And one thing that we have forgotten to do is to have qualitative investigation at the local level. We need to ask, people, what are their perceptions towards vaccination? Why are not they're receiving, the vaccines? It is because they don't trust vaccines. It is because the nearest center to get vaccinated is really, far away, or is it because they don't understand? There is these language barriers that also exist, or the cosmovision, the way that they perceive things, So we need to combine, having the vaccines available, the services ready to, with the vaccine, but at the same time to understand why people are not receiving vaccines. Because as Bill mentioned, most of people are still, willing to accept the vaccines. It's not a predominant matter of hesitancy or reluctancy. That exists and is part of the problem. But definitely we need to understand which are the barriers and adapt the services, because sometimes we're waiting for people to get, to the services. But sometimes we need to reach out, to them.
Be proactive.
And not waiting the arms to get to vaccine, but the vaccines get to the arms and ties. It's a matter of how to rethink the configuration of primary health care many times. And of course, considering these alliances with health sector, for example, to promote, the vaccination when the kids are entering into school it's a combination of factors, but we need to understand in its qualitative, approach, it's definitely something that we need to do and understand the context, because it is very different, for example, what happens in Mexico, that what could be happening in Argentina or in Canada. We need to understand the context, and that's like that of, recipe of combining different approaches.
So tailored qualitative research to really understand attitudes and how they may be changing and different among different populations. Natasha, Bill, thoughts on or recommendations as FIFA kind of gets underway?
Yeah, I could say a little bit about that, because it's from a public health systems perspective, where this is another mass gathering and this is kind of routine business. It's nothing unusual for, we know what to do. We put in enhanced surveillance, we encourage vaccination, we put out information, recommendations for travellers, reminders for local folk to make sure they're protected, and countries that and other countries will give their citizens advice. If you're going to the World Cup, remember there's a measles outbreak going on in the States, in Canada, in Mexico, wherever they're going. So that is a very well-trodden path, and it's worked well in the past. We had the Pan Am Games in Canada. We had the Olympics have happened in the US. We had the World Cup in Brazil. There was a huge outbreak of measles in Ukraine at the time, and there was no issue with measles during that FIFA World Cup. So I think we know what to do for these mass gatherings. You also mentioned spring break. That's actually probably more likely to bring issues, in that you get people from all over the world coming together. We had a Disneyland outbreak several years ago because of people coming, if I remember correctly, it was actually from Wales, And that spread to many other countries. So that's a trickier situation when people go on holiday, because often there are younger kids and who are playing together in holiday destinations. In 2011, we had a big outbreak in Canada, in Quebec, and that was linked to an outbreak going on in Europe at the time. So, I have been out in the media recently encouraging people to get vaccinated before they travel from Canada for spring break specifically, because we are concerned that they may come back with measles, which is not what they want and not really what we want to happen either, if they bring back measles to Canada.
Not a very pleasant vacation, I would guess.
No.
So I think all of you have worked together in different ways on measles eradication at the global level, at the regional level, and really looking at this, what was really kind of a promising movement, but now, especially since the pandemic and kind of lower levels of coverage, really now we're seeing more outbreaks in Europe and other parts of the world. As you think about, kind of that quest for really achieving eradication, elimination in all the different regions, what are some of the lessons that this region can offer, and what are some of the opportunities from other regions that we could consider adopting here? Bill, maybe I'll start with you.
Yes, thanks, Catherine. And yes, Natasha and I, back in 2019, were working together in thinking about the path forward toward measles eradication. And that has obviously been tabled in first part because of the COVID pandemic. But I'll say, one of the big motivators for that discussion was what I think the region of the Americas is demonstrating, and that is that elimination is a fragile state. It's easy to lose a measles elimination status if you don't keep your coverage up very high, really across communities. And so, I think, for me, the first lesson, if, to have these three countries in North America that certainly have the resources to maintain high measles vaccine coverage and maintain their elimination status, if they're struggling to do so, that sends a signal, I think, to other countries in the world that don't have the resources that we have, that this is a hard thing to do. And again, this point that elimination is a fragile state and can be lost was really one of the motivating factors for our discussions around eradication, because once measles is eradicated and there's no more measles virus circulating, then the risk goes down. But at a regional level, a country level, there is constant threat of importations, and if you have these pockets, these communities where vaccine coverage is low, as we've seen here in the United States and in Canada and in Mexico, you get outbreaks there, and that can reestablish endemic transmission. So there are a number of messages here, and I'll just put out some, and we can hear from Natasha and Daniel. But I think Daniel already highlighted the value of surveillance and really improving our surveillance strategy. But I'll also say sharing the data and sharing data across counties, across states, across countries and regions. Sharing our measles surveillance data so that we have this situational awareness of what's happening around the world and can put in preventive measures to both reduce the number and the size of our outbreaks.
Daniel, thinking about the, what Bill has said, in terms of, really marrying, and you too, the immunizations with surveillance and the fragility of elimination.
Yeah.
What are some of the lessons that you see, this broader region really kind of taking and sharing with other regions of the world?
Yeah, well, we have eliminated several vaccine preventable diseases that no other region has eliminated. But of course, measles is the most transmissible, and probably that's why we're seeing the reemergence of transmission in our region. But definitely the highest commitment, political commitment, because we have our member states in PAHO, they gather annually to have the Direction Council. And there, they agree on resolutions, to eliminate, for example, diseases. And for measles, it was the case. I mean, in the 90s, there was that high-level commitment of all the countries to work together towards elimination. So if you have that agreement, if everybody is working towards the same goal, it's easier. Of course, we now have a lot of different, diseases and priorities, and I mean, the world has changed. But if you find this kind of highest level of commitment, it's easier, definitely. I think that what worked in the past, for example, of having strong programs on immunization, strong managers, leading these programs, very good communication as was mentioned in the communication among different countries, among different even states. I mean, that's part of what we need, to have this shared information being available, being transparent, being timely, like shared. And definitely what worked in the past, it's not necessarily what is going to work now. And why am I saying this? Because we're living in 2026, and we have several countries that now they have an electronic immunization registry where they can easily track where the unvaccinated ones are, or the sub-vaccinated ones are. But the thing is that many countries don't have that. I mean, we need to continue working on that, and the ones that have this electronic immunization registry, that the quality of the data is not enough, or there is no enough interoperability, subnationally. I mean, that's part of what we need to continue doing. For example, microplanning. I mean, to have a good tool of microplanning to detect the pockets of unvaccinated, it's key. If you don't have microplanning when you're working on your routine immunization or the follow-up campaigns, I mean, you're losing ground. And of course, now we have geolocation tools. So if you combine, for example, having the birth registry linked to the electronic immunization registry, linked or using these geolocation tools, linked to this kind of the profile of why a specific community is not having high coverages with this qualitative approach, linked to engagement in all the levels at the community level. I mean, it's something that definitely is going to work, but we need this kind of commitment. We need the resources to be there. We need the flexibility of the healthcare, systems to be adaptable and to understand that sometimes having the vaccine available from 7 a.m. to 1 p.m. to twice a week is not going to work, because I mean, in Latin America, we have a lot of, in the Caribbean, we have a lot of people working in the informal sector. They are not allowed, to go to a healthcare center during the weekdays to receive the shot. Or, I mean, we need to extend what happened, for example, in the COVID-19 pandemic, extend the vaccination hours, or even to in the weekends. I mean, or having festivals or different activities where you can offer the vaccine to people. It's something that you need to understand and have your planned activities in place according to the reality of each population. And that's the recipe. I mean, if we would like to, show that example again to the rest of the world, that example is there, but we need to actually, modernize and update our strategies. And of course, the commitment, it's something key. And for example, taking advantage of social media, like positive influencers, I mean, it's part of what is needed now. Before, we didn't have social media. Now we have that, and it's part of what we need to take advantage of. Not just waiting for the misinformation to spread there, but to take advantage of that, tools to convince people, because it's a matter of convincing. If people is really convinced that they need, that their kids need the vaccines, I mean, they're going to look for it. But if we don't have that level of, convincement, we're not going to have, that high coverage that we need.
So, Natasha, I'm going to turn to you with maybe the last word here, or the the last words. But we think about like the goal of eradication, or certainly regional elimination in different areas. You know, we've heard about the importance of political will, political commitments, building trust, community engagement. Several of you have talked about that, but also just the importance of flexibility, meeting, you know, addressing different kinds of communities' needs and desires, but also just the fact that this elimination agenda can be very fragile from one year to the next, depending on many different trends. Things can change. I know you're currently working at the federal level, but you have looked at some of these issues at the global level as well, and you've talked about, you know, some of the importance of travel and migration and, you know, connections between so many different parts of the world. So as you think about, you know, kind of the year ahead and some of the lessons that can be shared across regions, what will you be kind of thinking about or focusing on?
There's tremendous commonality amongst the regions in terms of their desire to achieve elimination, but huge differences between their ability to do that. So this is going back to my previous role working at WHO. I am in favor of there being a global goal. That's not currently policy, but I think what we do need is a plan for how we're going to get from where we are now, totally recognizing elimination is a fragile state. But I think one of the lessons of these outbreaks is that if a region like the Americas achieves elimination, it's then hanging on, waiting for everyone else to catch up, waiting for one case arrived in Canada and we lost our elimination status with more than 5,500 cases. So something needs to be driving progress. And right now there's massive inequity because most of the deaths from measles are happening in 2 regions in the world, which not the Americas, and we haven't really got a push on to make progress in that direction. And the US was a huge player in driving in that direction in the past. So we're in a new world now, as Daniel said. So we have to find a new path because we're not going to have the same support. I think we do need some kind of global direction here. I also wonder if we could revisit traveling in general as new technology arises, or maybe we can get more partners to help us so that people don't travel with measles, or if they have been exposed, they can get access to post-exposure vaccination even, which does, if it's quick enough, can be quite effective. So because again, if we're not going to get rid of measles overnight in much of the world, but maybe we could try and slow its spread somehow. So I think we should be creative about looking for new ways forward, new technology. We haven't talked about patch vaccines. That might be a good way of, you could slap them on people at the airport, they can self-administer them. There's new things coming along all the time. So let's think creatively of a way forward that helps all countries make progress and raises the countries that are actually have the greatest burden.
Well, I want to thank all of you for joining me this afternoon to talk about what was a challenging year for this region last year. And it started out a little bit rocky, but it sounds like there are lots of opportunities for renewed collaboration and really, engaging with communities, building trust, and, rethinking how to communicate both about infectious disease and health and wellness more generally. So Daniel Salas, Natasha Crowcroft, and Bill Moss, thank you all for joining me this afternoon. And we'll look forward to seeing how things develop over the course of the next 10 months. So thank you.
Thank you.
Thank you.
Thank you.
you.